We have fantastic colleagues to come on stage with us and expand the discussion. So first of all, I'm going to ask Rosaline Mbayo to come on stage, who is a community-based social work researcher and director at Afrikaherz, and has 23 years of work experience in the area of migration and health, and is based in Berlin in Germany. So thank you so much, Rosaline. And Rosaline, I just want to give you the opportunity to give your reflections, first of all. Thank you so much.
Yeah, thank you very much for having me here. And although it was on short notice, but I mean, having experience or doing the work for 23 years, I mean, I think I have a lot of experience or information to share. Talking about the topic we have at hand, that the status neutral approach, is it affecting stigma? It's a question, I mean, that I cannot say yes or no. For the work that we do in Germany, because like, if you talk about, I mean, we have prevention, we have treatment and care. So you start with the prevention part. We do testing, but before the testing, we had to do a lot of work. We wanted to work with role models, key players in the community. We worked with African pastors, the churches, because as head of their house, if you get to talk to the head of a house or home, then you have access to the members as well. So we did training with them. I mean, we have to tell them what it means, because in the beginning, they were very much afraid. They didn't want to hear about HIV and AIDS. But after talking to them, we did the workshops in different German cities or states, and over time, they allowed us to go into their churches to, have role plays and trying to sensitize the communities. It was very important to build trust, because you have to build trust. There is a lot of fear. When we talk about stigma, we shouldn't forget about fear. People are afraid. And doing testing, people, are afraid, because if I do the test and it's reactive, what happens? Germany is quite different from other countries. Access to treatment or access to health care is depending on the type of visa you have. So if you don't have the right staying permit, then you don't have access. So that's how complicated it is. So we also have the language barriers, structural barriers, institutional barriers. All these barriers put in place makes it very, very hard. So what have we been trying to do? Apart from talking to the African pastors, trying to engage them, we also try to reach people in their safe space. It's very important that you meet people in their safe space, in their settings, and go to them, meet them, and you're able to answer their questions. Been doing some of the tests. Some people say, I don't want to do a test. What I don't know doesn't kill me. So, and also that I cannot just go to the prison and tell the officers there they should lock me up. So they don't want to do a test because of fear. So we have to break down the taboos. And I think it's not only within the African communities or the marginalized communities. It's a topic of the whole nation. There should be a lot of awareness raising, because a lot of people still don't know about HIV and AIDS is just within closed doors. And the awareness, of HIV, desensitization should be something that should be for everybody. So it's not just for the marginalized groups. And of course, when you talk about African communities, they're a community within a community, and they are really disproportionately affected. And that is why, we're trying to have peer-to-peer approach, trying to reach out to the communities through campaigns, educating them. That's the first step. When that is not done, the second step doesn't hold. And also, it's very important that for breaking stigma, all the stakeholders have to be involved. It has to be a participatory approach with affected people, infected people, service providers, everybody coming on the table, putting them in strategies. And also, it's very important to, first of all, analyze what has been working and what has not worked, why hasn't it worked, and try to bring up new, innovative ideas. Thank you.
Thank you so much, Rosaline. I've already got some questions I want to ask you, but we'll move on to our next panellist. So our next panellist is Garry Brough, who is works with Positively UK, which is an organisation within the UK, and he coordinates their national HIV peer mentoring training programme, Project 100, and developed its HIV treatment literacy qualification. And he actually stepped up as joint interim CEO from 2018 to 19, and is now the lead for peer learning, partnerships and policy, and managing the Fast Track Cities peer support integration and empowerment programme. So great to have you here, Garry, and just look forward to hearing your perspective on this topic.
Thanks, Vanessa, and thanks to the people who've already spoken for some additional thoughts in relation to what I had initially to speak about. And I think that the thing that's interesting for me, and the thing that I first thought of when I heard about the status neutral approach, was that it was a semantic exercise, and that whilst we've already talked about the importance of language and sensitivity to language, and that has the potential to change and challenge stigma, that a neutral approach to HIV status does not change my experience as a gay man living with HIV for 30 odd years. And therefore, we can change the language and we can change the services to make those services neutral, but we can't change society to make them neutral towards HIV. And so that was my initial challenge with it. Then with looking at things more, what it comes back to is that the idea that it is a whole person care approach, which is something I'm very, very much behind. And the fact that what this approach does is consider equality and equity in relation to that approach. So currently, I advocate for peer support within HIV clinics because I recognize that when somebody gets a diagnosis of HIV, the isolation, the challenge, the additional stigma that is layered upon their pre-existing life challenges that may relate to their gender identity, ethnicity, migration status, sexuality, class, all of those things are already something that has made them vulnerable to HIV probably. And therefore HIV on top of that is going to magnify, layer or exacerbate that. And so thinking about how important that is, I then have to think, so what about those people who are vulnerable to HIV, who come in for the test, get a negative test and then just sent home? If you don't have something that then supports them to live well, you're doing what we do very much in the UK, which is to have a national ill health service, not a national health service. So if we don't focus on prevention, if we don't focus on community engagement and integration, and in making people feel like they're a valuable person in and of themselves and a part of a wider community and society which cares about them, then we're failing those patients, those people. And so for me, the idea that this approach could provide an addition to the currently, in my experiences, excellent HIV care, to think about the sexual health and to move that from that model of sexually transmitted disease to sexual health, then that's a really good shift to make. And so the other thing that came up within that is this idea that it needs to be designed and delivered by communities. And I think the important part of that connection, that community connection, when it comes to HIV, most of us have contracted HIV because of a desire to be close to somebody sexually and to be intimate and to be more intimate than condoms provides, for example, as just one example. And so if this need for a connection is there, how do we then think about services that engage people in better human connections? And so it's a wider societal piece of work that starts in schools with sex and relationship educations so that people have a better understanding of their health, well-being and their place in society. But it needs to then address the challenges that we see around sexual ill health. The main problem with that then is the funding and the ability. The fight that I've been having for the last 20 years just to provide peer support in an HIV service, let alone to think how we might do that in a sexual health and testing service, in an era where we are moving to home testing, kits being sent out, you send them back, you get a result, and then you come into the clinic if you're positive, because face-to-face services cost more money, is our great challenge. And so we don't currently live in a society where the government values health in the way that it should, in my opinion. Not my organisation's opinion necessarily, although I think probably most of my colleagues would agree with me. And I'm cautious about being political, but HIV, sexual health, and health are political issues. And so until we have a greater value of health and well-being, we're never going to get to any kind of neutrality. So I support the concept, I support the potential to implement it, but I think for a semantic point of view, whole person care fits more comfortably with me.
Thank you so much, Garry. Great. And last but not least, we have Eli Fitzgerald. Eli is a trans man living with HIV, and he works with organisations such as CHIVA and Positively UK. And Eli's CHIVA's youth advocacy worker and youth project coordinator at Positively UK. So we're thankful that you're here, Eli. So look forward to hearing from you.
Okay. Shall I?
Yes,
yeah.
please do.
So, firstly, like Garry and Alastair, this was a new concept to me. Never heard of it before. And I still find it quite a challenging concept to understand, specifically as a young person, in which the sort of care pathway isn't necessarily the same. For a lot of young people, especially those born with HIV, there isn't that sort of, you know, you get tested and find out, you often just know. And that's your life. And then you're told that you have HIV. And that's sort of how that works out around that. And this is where I sort of find this concept confusing, in the sense of, does this sort of, how would this work away from this sort of sexual health clinic, and that sort of, how does it work in pediatrics, for example? Because if you're testing someone who is 16 or under and they come out negative, how do you then provide them follow-up support? Because there isn't necessarily that system in place to provide that support. And I also want to sort of mention on that, on the regional disparities that affect this, is that I have grown up in a rural-ish area. I mean, it's a small town, and it's in Wiltshire. And Wiltshire has no sexual health services, no support services. There is nothing there. It's one of the biggest counties in the UK. And if there is nothing there, how can we even provide this status-neutral approach? Because you can get tested, but you don't get support if you get tested. You can test positive, there's no support. You test negative, there's no support. GPs, local practitioners, any healthcare provider probably doesn't even know what PrEP is, and that's the harsh reality. And I think when we sort of, there was that bar chart sort of that was presented earlier, and I was looking at that middle bar and I was like, okay, yeah, testing, but when you get tested, and I think there's something around this which always shocks me, and it's never really mentioned, is the discrimination you can face upon testing. And as a trans person, I've heard multiple times of people who, trans people, especially trans men, who access testing and are then told that you're a trans man, you don't need PrEP, or you don't need PEP. And then they go on and test positive for HIV. And I think there's something to be said around that discrimination within testing services and the discrimination that follows, because you can't, for most services, we'll say most, it's very lovely. And I think, you know, we've got amazing services like Dean Street and other LGBTQ+ inclusive places. But if you're testing in the middle of nowhere, someone who's never heard of or treats trans people like they're some random new thing that's come out of nowhere, and they've got absolutely no idea what like transitioning even involves. And then also you're young and you're perceived not to be at risk, which isn't necessarily true. You sort of are placed in this in-between where you feel like you can't access these services because they are not designed for you. And I think I agree with Garry when he speaks about this whole person-centered approach, is that that's vital, but that's so specific to cities and big cities. And even then, they're terrifying. And as a trans person, I feel lucky that I have HIV because I can just ask my clinician to do my sexual health testing. Because I would not go to a sexual health clinic as a trans person because I'm scared I'll be turned away. I'm scared I'll be treated wrong. And that's not acceptable, and that's not okay. And I think we can have status neutral approaches and we can have all of these systems in place, but that doesn't remove the boundaries allowing people to actually access these services in the first place. And especially those who are terrified of them or don't even, HIV, as a young person, if I look at that more broadly, my friends who don't know I'm living with HIV, they don't talk about HIV. HIV doesn't exist. It doesn't affect us because we're just living our lives, and it's not spoken about. And I think something that shocked me recently was I work with CHIVA and their youth committee, and someone asked the youth committee a question about it's a sin and what they thought of it. And bear in mind, everyone on the youth committee is living with HIV, and there are all young people living with HIV, and all of them, I think it was all of them, hadn't even known that this show existed. It meant nothing to them. And I think we often view HIV and young people through this lens of, oh, they're consuming all this media, they love this. The media that most young people are consuming doesn't mention HIV. The world, for most of us, doesn't mention HIV, and we are in an echo chamber, and we've heard that many times today. And I think if we take ourselves outside of this, HIV is not talked about at all. So why would people who don't talk about it or even acknowledge it, why would they get tested? And I think that's something around that middle ground that we need to really look at a bit deeply. I'll stop there.
Again, I want to thank all the panelists and speakers because I think it's, first of all, it's just great to hear all the different perspectives, and already we've just had such rich reflections about it. And so I'm going to hand it over to the audience here and those online. Please keep sending through your comments and questions, but please, if anyone's got any questions they'd like to ask. Got one at the back there.
Thank you. My name is Dennis Anyango. I just wanted to sort of, maybe to all panelists really, the issue around, when we talk about discrimination, we talk about negative experiences in primary care. I think fundamentally it's also about how willing the clinicians are to take interest in somebody's situation or particular circumstances. And we've had often conversations around shared decision making, and how it is important to ensure that patients are involved, that we have patient-centered care, and patients are involved in decisions about their treatment, including treatment choices and managing HIV. My question is, especially to the clinical panel, the panels who are clinicians, whether this is really in practice achievable, given the challenges around time restrictions and the rare occasions when you see patients. Do you think that there is a meaningful, a realistic chance that you can actually have a positive conversation with the patients or engage with them to a level that they do not feel that they are not being listened to?
Thank you so much. I might hand that over to Professor Behrens.
You're asking the right questions, right? Is it realistically possible? You know, most infrastructure in healthcare, you would say HIV is easy to treat, things should be easier, it should be simpler, people go back to work, their life expectancies, you know, this is what politicians see and what, you know, people think. In reality, and that's what the prevention part brings in, people have lots of things that are challenging and put them at risk for HIV, and we don't have the resources for it. And the best thing you can have is that HIV specialists or clinics at least know where to refer people to or have close contacts to get things at least started and start with some of the issues, unemployment, health insurance, and other things to support. But that's what I fear, and I agree to what you said. If you put this on a paper like this, you know, outline and this very nice graph, if you think how much is needed to support this, it can only be justified if you've got lots of people going through all these circles. And this is why I think this is established in New York or explored and tried. And there also the campaign to go out and, you know, use other words like PrEP and we play safe and so on is probably useful. For many other places, as you mentioned, rural areas, you would say this is academic, very nice concept, absolutely in favor, but how do you do this, right? And that's still challenging. We see that now with, it's unfortunate, but it's with the refugee crisis that we need these resources again. It helps us at times to re-establish it, but I fear it will recollapse again as soon as things get a bit better, or we don't have funding for it anymore.
Mm-hmm. Thank you so much. Any other reflections from the panel?
I think in relation to this, there is that, and it does come then back to funding and the resource for services that tend to be then specifically for already marginalized populations. So that's the additional challenge that we have. It's not HIV stigma necessarily. It's homophobia, transphobia, misogyny, discrimination against migrant communities, all of the issues that we have real problems with in society, and that despite the fact that we seem to be going through, you know, a whole range of kind of progressions in relation to availability of treatment and becoming, you know, better at managing conditions, we seem to be worse at interacting with people as human beings. Certainly in the UK, I think we're going in the wrong direction, not in the right direction, and I see that, you know, echoed across Europe in relation to a lot of the political changes that are happening. And so until we think about those societal change, that we're going to be in a position where that's just not going to change. It goes back to the same point that Luca made earlier about sex work and the marginalization, the fact that those voices are not heard. And so I think for me, I kind of wanted to ask the panel at that point, so if what we need here is structural change and a different society, how are you going to do that? And then I thought, no, I can't ask that. That's a really mean question to ask. But then I thought, well, actually, it's a question that I'd answer, is that, will I stand up and I be counted? And I think that's one of the things that this is looking at, and it's saying, you know, that every person that comes in to seek a test needs to be valued and be seen as being important and have their needs met. But the other problem with that is, as Eli said, there are a whole bunch of people, and certainly in countries where we're already at the 95% diagnosed, that last 5% are not going to be the people that think they're at risk of HIV. And that's where we have that challenges then in relation to how you get that information out and how you make services friendly and accessible enough to have them engage with it, because those people are not hard to reach. The services are just invisible or hard to access. And so that then it becomes the challenge for us. But I think visibility clearly is one of the things that we can do as a community to try and raise awareness and engage people more effectively.
Thank you so much. I'm mindful to go on to another question, but I can't help but say, you know, about distributive justice when it comes to funding. We really need to send to the most marginalised and have that follow in our funding. And I saw someone else's hand go up. Great.
Thank you. Ian Muchmore, I guess I'd call myself an HIV advocate, and I'm hopefully following through on that. What I heard was that this concept is, there's a bit of rhetoric in here. It's a nice idea. The concern is it's a bit beige, and does it really lead to the stigma change that we really want? So back to the experts on the panel. I know we want to change the world. We're all doing HIV advocacy, but I'm interested, have you got a burning, actionable idea that will especially take us out of, I'll be honest, the obsession that we have around HIV and dealing with it in the UK within sexual health services, we're afraid, clearly, to go outside that model. I've lived in Australia for 20 of the last 21 years, and I've seen other models. But in the UK, it's all through sexual health services, and I feel that is exclusionary, and that's not going to meet the stigma things that we want to do. So have you got one thing that we could get behind, anyone on the panel, that would be, from an advocacy point of view, would begin to make that change, begin to break the system that we've got at the moment, so there is less stigma in the system? Any ideas?
Maybe if I can just answer that. I think there's lots of things that are on the table. I agree with Garry. I mean, I think sort of e-health and kind of postal services are really challenging. But the bottom line is, the buildings that we have, even if we did have 20 new staff going into a sexual health clinic, you don't have the rooms. The capacity issues within these services are at breaking point. I think really what's happened with monkeypox has really evidenced the vulnerabilities that we have within them. I mean, you know, I had a call at HIV Scotland. Somebody was asking me about a TikTok video to remove a contraceptive device because she was keen to start a pregnancy journey. I mean, and I'm kind of going, you know, I know about these videos. I've actually seen them. They're kind of quite horrific, but starting your pregnancy journey with a trauma is not the best way to go. I think things that we have in Scotland, we've got HIV Scotland are running the first national postal home sampling service. And it's new, it's groundbreaking, there's things that we could do better, things we're learning from. But I think things like e-health and how we're engaging, I mean, that service, the uptake is 41% women and girls, and it's 54% heterosexual people that are engaged. So I think how we're going to use postal services and other mechanisms, it's a new science, it's a new space for certainly testing and access, and the wraparound stuff in terms of prevention and pathways into other things that are required are being identified and established as we go, because we're in some ways building the ships as we're sailing them. But there's no option at the moment, because services, quite frankly, just do not have enough rooms and enough bodies to get people through the way that we need to. And co-production certainly is a very, very important thing, but it's a very expensive thing to do properly. So there's a whole system thing that needs to be considered about how we actually deliver these services, co-produce them with community, and really assess and engage with the needs that are required.
And Garry, I'll give you the last comment.
Thanks, Alastair, and thanks for the question. So I'm the community rep on London's Fast Track Cities initiative, and as Vanessa mentioned earlier, the 3 work streams around addressing stigma, to work with people living with HIV who are experiencing stigma internally, and to be able to support them to feel more comfortable with their diagnosis, more comfortable to live well with HIV, and potentially, should they choose, to be able to talk to other people about their status. That for me is the first part of it, because you have to start with people living with HIV, and you know, so it's an inside job. But then once you do that, the other part of that then is, okay, so how do we make services and the support that people access HIV friendly? And so the charter mark and the inclusion and training of HIV ambassadors to be able to speak more publicly about this. Society changes only when they understand the issues better, and we understand that as humans by hearing other humans. And so public awareness through lived experience for me is the important thing. And so when you take that from the places and into society, hopefully that changes. I remember a time 20 years ago where people whispered the word cancer because it wasn't acceptable to talk about cancer. And as a community, we have the ability to change that perception of HIV. And so to steal Terence Higgins Trust's campaigning phrase around "it starts with me," I take responsibility for that. I don't expect that anybody else should have to. And I heard the issue for the woman in Amsterdam there in relation to not everyone can or wants to or should have to stand up and speak about that if they don't want to. But if we can, those of us who can and will and are willing to do that, we have the potential to make it a better world for those people, should they ever want to choose to do it. And so for me, it always ends up coming back to the personal, and that's where the action is for me within this. And that's why I want to work with the systems that are in existence to improve those and to integrate that support within them.
Thank you.
So that's
so
my
much.
answer.
We have one more question, and I just want to acknowledge those online, because we're getting fantastic interaction where people are reflecting about different scenarios. So a lady in Africa, in Tanzania, was saying that she feels that we need more education and knowledge about PrEP amongst health workers, and people are talking about this strategy, but in countries where people at risk of HIV cannot come cannot come out openly about their sexuality. So lots of discussions, and thank you to those online. So,
Thank you so much. My name is Tinashe, grateful for words from the Global Network of Young People Living with HIV, also known as Y+ Global. I'd like to learn from the panelists on how are they involving young people to lead and inform some of the interventions that you have also mentioned. In our work, we have also realized that young people, they are not a homogeneous group. We also have young people who are in correctional centers or in rehabilitation. We have young people who are living with HIV and who also have a number of impairments. They might be having disabilities. We also have young people who identify as LGBTQ+. But they also identify as young people who sell sex. So I'd just like to learn on how are you involving young people in designing the interventions that you have shared, and how are they also at the forefront of leading those interventions? Thank you.
Okay, I will talk about the German experience. We have, in our test projects, we have young, people from different countries, because we want to make sure that we have, there's access to different groups, and we involve them. For example, when we want to come up with information materials, we sit with them, because as young people, they know how to reach, their peer groups, so we engage them, and they are part of, the development in our projects. They talk to their people. They have this WhatsApp and the social media. They engage with that, and they have their groups. So that's how we've been working with them.
Last word, Eli.
So there's many ways of involving young people in the work that I've done, in the work that we do at the Positively UK Youth Project, and also at the Children's HIV Association. And I thoroughly believe in that there is nothing about us without us, and that concept of, if you are having something that is for young people, that should be run by young people, in a sense of how peer mentoring works. I think one of the amazing things, I'll speak firstly about CHIVA and what happens there. I think firstly, one of the amazing things about CHIVA is that they've got their youth committee, and their youth committee is I think it's about 20 young people, all living with HIV between the ages of about 15 to maybe 18. And they meet up regularly. They are they're amazing. I'm just going to say that. And, but in a lot of policies and talks and attending international conferences and ensuring that they have a voice, I think that's an absolutely vital thing, an amazing thing that they have done for years now. And I remember myself at one point, I was on that committee, and it helped me grow as a person, but also understand HIV. And I think there's something about the importance of giving young people a voice, despite the stigma, despite the fear, and also allowing them to explore that, but also have a say in how their care works. And they've done this amazing thing at the moment of HIV in schools and education and policy around that. And CHIVA have some amazing guidelines for teachers to understand how those living with HIV who are in schools should be treated, and also a toolkit workshop program, so that during sexual health, which when I asked sexual health and not sexual, I meant sex education, and how that works in schools currently. So I emailed them and I asked, is HIV an actual talking point? And unfortunately they got back to me and said, well, it's up to the teacher to discuss this, but it is in the program. And I think that's unacceptable. So I think it's amazing that, these young people have seen an issue, they fought for a solution, and now that throughout many schools across the UK, and I recently did a talk in a school, we're talking about HIV in schools, because that's where that's the starting step of young people's lives, and that's also where stigma is what I feel is most prevalent at some points. And I remember being at school and being told that the local river has AIDS in it, and then purposefully going for a swim just to make that a true fact. And I think, okay, maybe not AIDS, but yeah. But I think, having young people involved in that such policy, the guidelines, the asking them and having them at the table, because so often we don't have a seat at the table. And so often I feel like I'm the youngest person in the room, and that's ridiculous. That's not okay. And young people are also often sort of accused of not having the expertise that they do because they're young. But actually, for a lot of young people living with HIV, they could, in some cases, be the person in the room who's been living with HIV the longest. And to then assume that just because they're young, they have a lack in expertise and a lack in experience is unacceptable. So to reassure young people that actually you do have these expertise. And then in my work at Positively UK with the Youth Project, we talk to our young adults and we ask them what they would like from us, because it's about them. Our service is for them, and to ensure that they have a service that caters to their needs. We go into clinics and we just ensure that sort of everything that we do is for them, but also from us, so we can relate to their experiences. Because, you know, so often in my life, I've had people double my age, not understand at all, try and tell me that, oh, I get it, I've been there. No, you haven't. You haven't been there. And that's just the reality. And I think I thoroughly believe that having young people, giving them a voice, having them a seat at the table, and just listening. We all need to listen, because that is how we make change. And so often I hear, young people are the future. The future is young people. But we're not paid to talk about our experiences. When we talk about our experiences, we're often talking about our trauma, and just the expectation that, oh yeah, they're young, they can talk about it, it's fine, we don't need to pay them, it's no big deal for them. And also just understanding that as young people is not one category. We experience so many different intersecting inequalities, and it often isn't just you're young and black, you're young and poor, you're young and disabled. It's more than one of those things. So understanding that young people are more than just young. And yeah, I'll stop it there because I could go on for hours and hours and hours.
You know, I think that is a fantastic way to end the panel. You put it so beautifully, and I'm sorry that I know others did want to ask some questions, but we are pushed for time. I just want to take this opportunity to thank the panelists again. I think that's been a fantastic discussion, so thank you so much.